Good evening, everyone. Today, I'll present a paper on the profile of surgical cases attending minor operation theater in a tertiary care center. Now, to introduce, we all know that ocular morbidity are usually caused by both visual and non-visual pathology. According to WHO, as on 2020, there will be 230 million people who will be visually impaired. Majority will be caused by cataract and undercataract visual error. That already most of us know. But when I search data for the morbidity regarding non-visual ocular morbidity, as there is always primary focus on the cataract, we often miss non-visual ocular morbidity. So what I want to do is that we wanted to do a study with the aim that we wanted to, evaluate the epidemiological and clinical profile of minor operation cases attending a tertiary care center. It was a hospital-based retrospective study. After taking ethical committee clearance, the epidemiological and clinical profile of the cases attending minor operation theater of AIOC2024 are evaluated in relation to age, sex, anatomical site, the type of surgery performed, etc. Yes.
Chandra, I think we just have some technical issues.
Okay.
And the judges, they are not able to see the presentation. Can you hold on for a minute?
Yeah, sure. Not much done already.
Now you can start.
Can I repeat?
Now you can start.
No, I can repeat or I'll continue.
No. Carry on.
Okay. So after taking ethical committee clearance, the epidemiological and clinical profile of cases were recorded in relation to age, sex, anatomical sites, types of surgery performed, etc. Our study period was from 1st January 2018 to 31st December 2022. The minority procedures are usually defined as procedures that are superficial, limited operative field, and a minimal access intervention. Now I think this, okay. Now coming to our result, the duration of the study was 5 years and total case was 3037. Male-female ratio was slightly, male was more and age range was 2 to 79 years. Now when I see the anatomical side, the most common side was eyelid or eyelash, then was nasolacrimal system, conjunctiva, anterior segment and whole globe. Now, if we see, most of the cases were DCT followed by DCR, then corneal tear, pterygium, collagen, lead repair, excision biopsy, tarsorrhaphy, evacuation, and entropion. Now, when we see the lead cases, it's considered 36.3% cases. Out of this, the most common was collagen, then lead repair, excision biopsy, tarsorrhaphy, entropion, and ectropion. There were 12.7% conjunctival cases, most of which was pterygium, some were excision biopsy, and some were others. Then nasolacrimal system had 32.4% cases, most was DCT, which was slightly larger than DCR. Then the globe involvement was 5.7% cases, and most cases were evisceration. There was sclerocorneal tear in 13.3% cases, majority in the adult with a 73.6% incident. And excision biopsy cases were 8.4%, and the result of excision biopsy were most of the cases it was benign and calculated others, then followed by granuloma, then different tumors which were benign and non-benign as well. Now, in our study, the most common side is eyelash, as I have already said, which was followed by nasolacrimal system, anterior segment, conjunctiva, and whole globe. The most common surgery was DCT, which was followed by DCR, sclerocorneal tear, pterygium, collagen, lead repair, excision biopsy, tarsorrhaphy, evisceration, entropion, enucleation, and ectropion. And majority of the cases are done under local anesthesia, but pediatric cases are done under general anesthesia. Now, coming to our discussion, most of cases are based on eyelid followed by ocular adnexia. As minimum access needed in these cases, plus use of local anesthesia, plus high occurrence of lead pathology as well as trauma, this makes these cases major contributor in case load. Now, incidence of nasolacrimal pathology is 7.9%, which was higher in studies found in Dolges et al., etc. Incidence of anterior segment pathology in the form of corneal sclerocorneal tear is 13.3%, which was slightly lower than that of Humphrey et al. Study. Pterygium incident in our study was 10.9%, which was comparable to the study of Sanjay Singh et al. The excision biopsy percentage was 8.4%, which was mostly benign, which was comparable to the study of Gautam et al. Incidence of blood-related surgery is 5.7%. Most common is evisceration, which was mostly due to trauma. This collaborates to the study of Osama et al. Now, coming to conclusion, from our study, it is seen these minor cases cause a lot of distress in large number of people. But as we always emphasize on visual impairment, that is mainly cataract, these cases are often missed and underestimated. Now, if we see properly, there is no already established study, and when we search internet, there is no study regarding the incidence and profile of minority cases. But our study now shows that the importance of developing adequate infrastructure and training of young ophthalmologists in oculoplasty procedure so that the patients suffering from these minority cases can avail a better and prompt care in near future. These are my selected references. Thank you.
Thank you, Dr. Chandana. What was your take-home message here? I mean, beyond the fact that for young ophthalmologists, it's probably the first exposure to to do ophthalmic surgery. I mean, we all started with doing entropion and ectropions. Beyond that, what else?
See, there are many surgeries, entropion, ectropion, ptosis, collagen, whatever we do, evisceration with ball. Most people do evisceration, but they don't put the implant. And enucleation, etc. Many people are not doing, we are doing enucleation, but how many are actually giving the implants, intraocular ball implants to make the eye mobile? Yes?
I didn't get your last sentence.
No. Suppose all people are, if we see properly, when I see my setup, many people are doing evisceration, enucleation. That's fine. But how many are actually doing actual procedure of putting the implant ball to make the eye actually mobile, all the cosmetic part? That's not done.
You're doing that in the minor OT?
Yeah,
the
of course.
Placement of the implants?
See, there are two portions of the minor OT. One is for repair, that is external minor OT where we do infected cases. Another is for implant and all. What I'm saying is that
there are two separate areas.
Yeah, exactly.
Okay.
So
Right.
all these things has to be learned properly. Ptosis also, everything.
Ptosis also is done in the minor OT?
No. Yes, in minority. Only cataract we are doing in our majority, in our hospital. That infected, not infected. We have two minorities.
Yeah, you said
Okay.
that. And what pediatric cases you do under general anesthesia in the OT, minor OT?
That ptosis and DCR, DCT, and lead repair, not DCT, lead repair, etc. Everything is collagen is also we have to do under pediatric minority in general anesthesia.
Yes. Okay.
Thank you.
Okay, just one last question.
Sure.
What was the inclusion criteria for considering the case as a minor operating case? And this is a major operating case and this is a minor operating case.
As I have already defined a minor, if you see my first slide, we have already defined the definition of minor operation cases. Can I go back to my first slide, please? Oh, the Ajahn presentation has already come.
You can say verbally
You
actually.
can tell us.
Yeah. What we decide is that minority procedures are locally accessible, minimum invasion, and minimal locally infiltration anesthesia. This is the definition of our minority cases.
Okay, because the only, I think that DCR is not a...
Yes, ma'am. No, ma'am.
No, I just want to ask, you have a operating microscope in your minor OT?
Yes, of course, we have one.
You use that and you do?
See, in some cases, definitely indirect corneal tear repair, then you color pterygium, etc., then intubation, etc., we use that one. But for the major lead repair cases like RT, etc., we don't need that one.
You do not need?
Need for the lead repair for major RTA cases, for that everything, we don't need in all cases.
What, operating microscope?
Yeah, because...
Suppose the lead repair needs a canalicular repair?
No, that is what I'm saying, that depends on the case. It's case-wise, because it's a government setup and some nights we have so much caseload of all repairs, sometimes it's not possible. Only selected cases we put under microscope. Yeah.
I would like to emphasize that by no stretch of imagination is a ptosis or a DCR surgery considered minor or a lid repair. I mean, these days we give equal, like equal importance to these kind of cases. It should not be considered as minor, and lid repairs are very, very advanced these days. And this should not be the take-home message at all, that you do ptosis surgery in a minor OT or a DCR or an evisceration with implant. No, according to me, no. That's not the message that you guys should be getting.
No, the thing is that, ma'am, in medical colleges, in government medical college, we have to label it like that. That is why I'm putting it like this.
Yeah, that's fine, but
Yeah.
I'm just saying, I mean, let it not go ahead that, you know, this can be done in a minor OT. No, it can't be done. It's not the correct thing to do.
Okay, ma'am.